Now, you talked about the defibrillation of patients, and I know, these guys don't know, but at the regional level from the protocol, we're talking about what to do with these refractory cases for VFib VTACs, right? And right now, there's just a little blib down on the corner of
double sequential shock sequence.
Yeah, there's just this little this little blib down in the corner about that, but it's a little more complicated than just try double sequential or try an electrical vector change, right? So if I shocked him with my pads here and here across here, and that's not trying something else, right? I mean, Einstein's definition of insanity, same thing over and over, right? Or two devices if you are so equipped, right? With the take-home point of don't phone a friend, don't have a helicopter come within a second, if you happen to have it, use it, right? What else in that refractory case do you want to consider, and some of the points I know that are rattling around in there?
So basically, refractory VFVT probably has a similar mortality to asystole and wide complex PE. These people don't do well if they didn't convert with the first dose, and so you're exactly right. You can try changing the vector. You can try using a second monitor. So if you're going to change the vector, leave the pads on and just put the other pads on, because then if a second monitor shows up, you just plug them in, you're good to go. Yeah. And double sequential, just for anyone who's unsure, is you're not clicking the button at the same time. It's truly a sequence, so you should go click, click, like not directly at the same time, but pretty darn close is the goal, within 1 second. And then the last is medications, right? We carry amio, so you can give 300 followed by 150, and then some squads carry lidocaine. Lidocaine is very reasonable. It's 1 to 1.5 mg per kg, so that's another reasonable dose. We have lidocaine for medication administration after an IO to kind of take the edge off a little bit. It's not explicitly in the protocol, at least here, is something you can give, but it's something reasonable. I mean, we do have lidocaine in the drug box, and if everything is failing, you can always call med control and say, hey, we have a little bit of lidocaine, can we give this a whirl? And if it works, great. I mean, potentially save someone's life. So it's just something to consider.
So scanning over those notes that you had, there was, and I believe it was in the refractories, note about Esmolol somewhere on there. I wanted to bait you on something, so let me bait you on something. So that ends in LOL. Does that mean that the other LOL drugs, the other beta blockers in my drug box, are acceptable in these cases?
It's potentially something that could work, but that's not kind of something that's been seen in the literature. Even using Esmolol for this is still something that hasn't been proven. It's not standard of care. The reason we use Esmolol but not something like metoprolol is Esmolol is super short acting, so you basically get the heart to stop fibrillating or having electrical storm, but then you don't also then have it lingering around and harming contractility and cardiac output and all that stuff. And so that's why Esmolol is used, but not a longer acting agent. But then the other thing I forgot to mention, if shocking is failing, is if you shock someone once or twice and you're close to a tertiary referral center that does eCPR, which is ECMO CPR, that would be one of the few situations where you would actually make this a load and go patient, where you'd say, hey, I know that I'm going to provide suboptimal care and transport, but this is a young person who meets whatever the criteria are at that hospital for eCPR. Their best shot may be putting them on pump and then fixing the issue after they're on ECMO. That's not for everyone, but it's for certain places and certain patients.
Yeah, let's tease that out so we don't make sure we don't get the wrong message out of there. If you don't know about that in your area, you're not doing it.
Correct.
Okay.
Correct. This is pre-set up in a protocol for you.
That's nothing that it is a thing, and you reference to go on pump, right? That's where resuscitation is ongoing, and you're essentially doing a bypass, right?
Yep.
With ECMO as the bridging your heart, right?
Yeah.
To be overly simplistic in the explanation. And centers that are doing that, they're literally wheeling people in, CPR in progress. They've failed some defibrillations in the field. They're getting cannulated, bypassing their heart, and then they can take, I'll say, all the time they want, but they certainly have more time to figure out causation, etiology, and hopefully correct the underlying underlying thing.
The reason that needs to be protocolized is because from time of arrest, if you meet all criteria, you need to be at the hospital and starting to get cannulation within 30 minutes, and then be on ECMO within an hour of death, not just when you arrive, but when the patient had a witnessed arrest. So that's why it's very select populations can do this.
Yeah, so basically it's, the ring around the major centers, right? I mean, this isn't something that's coming to a farm field near you. I mean, it is what it is, right?
True.
It's not. You're not going to get them to a center capable of this intervention quick enough. So
some other potential patients that you'd want to take to the hospital while you're working them, because there's few things where the hospital can offer something that you cannot. So one of them would be if you think the patient died of a big PE. So if you think there's a big clot that is in their pulmonary artery and their heart just stopped because it's clogged up with clot, no matter how much CPR you do, that person's not coming back. What they need is TNK, or really TPA, that's similar, but it's what's recommended to break up that clot. And so that's something that only the hospital's going to do. So if you think this person just had surgery, just got off of a transcontinental flight, they have a swollen leg, and you're like, that is a PE for sure, narrow complex PEA arrest, I would just immediately work on bringing them to the hospital while doing whatever you can en route.
Good 1 minute, dead the next. The story fits, right?
And then another one
at Portage. We had that at Portage one time.
Awesome.
I don't remember if Dr. Hill was there yet or not, but Dr. Gupta, the interventional cardiologist, came down and we did that. We did the push, continued to circulate it with all the timetables that it requires to try to get ROSC.
It's a Hail Mary. It's almost positively not going to work, but it's the only chance they have.
Yeah.
Right. And then another one we kind of mentioned was refractory VT, VF, where you want to consider Esmolol. That would be very reasonable, where the hospital has that, but we don't have that in the field.
And that's the point I wanted to make, right?
And then hypothermia is another one, right? If you think that they died from getting cold, we're going to bring them to the hospital to warm them. But remember that all people will eventually get cold when they die. So you think they died of something medical and then got cold because of the environment they're in, that's not a hypothermic arrest. That's just a person who died and got cold. So if they died from hypothermia, that's an automatic transport because they need to be warmed for hours and worked for hours. And then another one would be hyperkalemia. The reason is if they died of hyperkalemia, they need tons of calcium. We only carry a gram or two, and so they may need 6, 7, 8 grams of calcium, and so the hospital is going to have all that extra calcium to potentially get ROSC for them.
And maternal arrest.
Yes.
Yeah.
Because the other thing we would want to do is we may not be able to save mom, but we might be able to save the fetus in that situation.
Yeah. Absolutely. Well, what other general things in cardiac arrest are your pet peeve / system improvement things that we really need to hone in on?
So one thing is is a way that we can increase the amount of compressions we're doing, right? The goal is to pause for the least amount of time. We set a cutoff of 10 seconds, but if you can have pauses under 5 seconds or 4 seconds, that's better. The less time we pause, the better. And so when you're shocking, you want to make sure that you're continuing compressions while you're charging. So let's say you're doing manual CPR. You get off the chest, you see the rhythm, it's VFib. You should get back on the chest to do compressions while the device is charging, and only hold compressions to shock. So once it's ready to go, you pull off, you shock, you get back on the chest without looking at the rhythm, check it again in 2 minutes. If Lucas or some other mechanical device is doing the compressions, you can shock it right through the Lucas device. So the only pause is just to figure out if it's VT or VF. You click Lucas back on, you charge while Lucas is running, and you shock while Lucas is running. So just let it run the whole time.
And this is where a big debate comes in on manual mode as opposed to AED mode on your monitor, because I can read VFib, VTAC a lot quicker than an analyze will.
Correct.
So that is one push that I have. But remember that if you're in manual mode or AED mode, you can always switch to one or the other pretty quickly. So you're not stuck there.
Assuming it's a multi-mode monitor.
Yeah,
because if you truly only have an AED, then...
But in that case, I'm not waiting the 5 to 7 seconds it takes for the machine to interpret my rhythm. I can read it quickly, get right back on the chest, charge my machine, and like you said, if it's Lucas, I can just charge and shock, and then I'm going good for another 2 minutes. Yeah. So I think that's important to remember.
The other thing, too, is remember, and I've seen this on some code stats, is make sure that your monitor is escalating the joules. Now, LifePak 15 is programmed that way, but I also want to remind providers to be cautious of, if you turn a LifePak 15 on and it's programmed to default energy protocol, which is 200, 300, 360, and this is specific to Stryker, at any point in time, if you touch the energy button, it now knocks that protocol out. So if you accidentally like click it just to make sure, hey, I'm at 200, which that's an old habit for a lot of us that have been around for a while. That's where it's going to stay.
Unless you manually adjust it.
Unless you manually adjust it every time. So if you turn your monitor on, hook the pads on, it's V-fib, shock, we do my 2 minutes CPR, shockable rhythm again, it's going to do it on your own. But as soon as you touch that energy selection button, then you are going to have to adjust it at every time until you get to the cap, which is 360 on Stryker's product. So just be cognizant of that, especially in somebody that's in refractory VF or pulseless VT.
Perfect. One other thing I wanted to kind of discuss, another one of the things I've noticed with some of my crews when I review things is we should never be holding compressions for airway. Clearly, it's going to be easier to get an advanced airway when compressions are held, but we already know that compressions are far more important than advanced airway. So if you can take a look and get that airway through compressions, great. Put in the ET tube, perfect. But if you're like, you know what, I can't do this, I want to say hold compressions, bite your tongue, do not say those words, and just put in a supraglottic. Just because you didn't get an ET tube, I wouldn't call that a failed airway. I would say that you made a expert decision based on the person looking that this airway was not going to happen through compressions, and it was better to maintain compressions and throw in a supraglottic. And I'll applaud that every time. Yeah. Heck, if you decide I don't even want to go for an ET tube, I'm just going to throw in the supraglottic in 2 seconds and move on to bigger and better things, then that's often even better. And there's data to say that just going for a supraglottic before an ET tube had been associated with better outcomes. And so just something to consider. But I'm not going to say don't try an ET tube. I'm only going to say don't try it by holding compressions.
We're running out of excuses, too. I mean, VGL makes it so easy.
You beat me to it, right?
Video-guided laryngoscope. I mean,
Yes. Between a video laryngoscopes and train that way. You know what I mean? Yeah. Train that way. Mm-hmm. Like we have sim mannequins for a reason that you can do CPR on or put a Lucas on and intubate through compressions. Granted, that's the best we can do in our environment, but train that way, 100%. Mm-hmm. We actually did that as a training in our organization, and it was you had to get 3 intubations to get out of training, and you weren't allowed to pause. And it was just and they're all like, okay. And I'm like, no, okay. And then,
okay. Please, for the love of God, if you're close enough
and
you're listening and you don't have these mannequins or whatever, call me or Scott, and we will set up a time and do them with you.
Call him.
Call me.
Call me.
Call Caleb's 900 number.
We'll put the phone number on the bottom of the screen.
Call now.
And for context, I often, if there's an arrest in the ER, I don't exchange that supraglottic for an ET tube. So if you bring me a cardiac arrest that's still an arrest and there's a supraglottic in, I am not exchanging that. If we get ROSC, then I will safely work to re-exchange that. But until we get ROSC, a supraglottic is sufficient, especially if you have good waveform and things are easy to bag. That's totally an acceptable airway.
What's your stance on pre-hospital NG-OGs? Let's say somebody's been vigorously bagging this patient, and you have a distended abdomen, and then you get your tube. What's your stance?
So if the stomach is big, that in itself can cause cardiac arrest and respiratory failure and cardiovascular failure. So if you've, because of your need to resuscitate that person, have unfortunately put a lot of air in the stomach, then please put in an OG because you won't be able to get ROSC. What that distended stomach does is 2 things. One, it pushes on the diaphragm, so you can't actually bag the patient effectively, and it compresses the IVC, so you can't actually fill the heart and get venous return. So you may need to decompress that stomach, and I've had a couple patients arrest on me in that process because we had to bag them as a part of a difficult airway, and they arrested, and the only thing that kind of allowed us to get ROSC was quickly getting in an OG.
He's got to throw it in at some point, right?
He does. That's like his hot button. That's his thing.
Do you like or don't like OGs?
No.
He is pro.
Yeah, he's gonna slip that in wherever he can. But I have to remind the audience, as of the way the protocols are currently set up, just because Caleb said so, and it's a good practice. You don't have a procedure for it right now, and you're not getting officially trained on it. Yeah, whether that changes, in the future, that's discussion for another time. But I had a helicopter come on scene one time, and same thing. It was one of the first things they did, right?
But that's just it. I mean, remember, and I've said it before, we've all said it before, AirMed's there, helicopter systems are there. It doesn't mean they need a transport. If you just need another set of ACLS hands or good medic or nurse or blood product, call them. If you can't get an airway, call them. let them help you. You can ground transport.
I mean, air medical transport will never transport someone in cardiac arrest. There's just no real indication. You can't fit the Lucas or other mechanical device in the back of an aircraft running, and you can't do good compression in the back of an aircraft. So if you call someone for someone who is alive and then they arrest when the crew arrives, they're just going to help you bring them to the hospital if they can't get ROSC. If you get ROSC, sure, they'll take them if it's indicated, but they're not going to take them if they're in arrest.
Yep. Yeah, let's talk about the big opportunity we have to save this patient from the neurological standpoint after we get a perfusing wiggle on the EKG, right? I'll tell you that story later.
I don't want to hear that story.
Perfusing wiggles on the EKG, right? I think a lot of times in EMS's mind, it's like, my work is done. I've got a heartbeat back. Time to go. And again, this plays into we have an opportunity to optimize.
Yeah, so I mean, you hit the nail on the head. You did a ton of great work. You got ROSC. Give yourself a clap on the back. Take a deep breath, and then realize that there's no rush to leave. The biggest risk to this patient is rearrest, and they're very likely to rearrest, right? Whatever killed them is still probably at play. You just got their pulses back. You didn't fix the issue, and they were just dead for a period of time, and that's going to lead to a whole bunch of organ failure and likelihood of rearresting. So the most important thing is optimize everything before you move the patient. So make sure, get a good set of vitals and fix anything that's abnormal. Hypotension is bad for the post-arrest brain, hypoxia, hyper or hypocapnia, all of that is bad.
My
so
goodness, you're following your H's
everything.
and T's even though you have ROSC.
Exactly, yeah, because it potentially killed them before, so let's not let it kill them again.
Right.
And the percentage of that being because of a STEMI is pretty high as well.
It's possible,
So you
and
should
that's
probably take your patient to a cath lab if possible.
Maybe. I mean, that's the thing is if they died of a shockable rhythm and they were complaining of chest pain or you had reason to believe that, or one of the important things to get is always get a 12 lead in the post-arrest period, because if they do have a STEMI, yes, please bypass the nearest hospital if it's not a STEMI center. They need to go where somebody can get a PCI.
So I just gave this patient a bunch of vasoactive medicine, right? 2-3 rounds of epi. There, I get him back. What's that post-arrest 12 lead going to look like? Most likely is there's going to be there's going to be a ischemia. There may be even infarct patterns all over that thing just from the vasoactive meds. Do you think that is something that? Yeah, I know why that's there, but does that change anything from our decision making? Like if I gave him the drug and said, if I gave him all this drugs, it's just post arrest, it's just vasospastic, right? I'm just gonna take him to the closest hospital rather than a PCI center, or do we always err on the side of caution and just take him PCI center?
Yeah, our job is always assume worst first, and so we do know that right after you get ROSC, the epi that's on board is probably causing issues. The fact that they died is probably causing issues. And so what we found is you may see a STEMI pattern on the initial EKG, and then 10 minutes to 20 minutes later, it won't be there. But by that time, you're probably at the hospital if you kind of are nearby, so that'll be more for the ER. So I would say if they have a STEMI pattern, doesn't matter whether it's from the epi or not, we're going to go to a PCI center. Yeah. If they don't have a STEMI pattern, then you don't need to.
I want a consolidated, easy message to remember, right?
That's just the way we do business too. Like it's always
because you can't know.
Go to a PCI center, and then if they need it, they're there and they're at the right place, and then it avoids an unnecessary transfer. So it's just better to go there from the word go.
And if they don't, that PCI center is also likely a more capable facility anyway. 100%. To deal with this complex case.
If you're really far away from all hospitals and you really don't want to necessarily drive 40 minutes when there's another hospital that's 15 minutes away, you can still wait 10 minutes while you're obviously extricating and doing things. If it's been 10 minutes, get another 12 lead, right? Just a piece of paper and look at it. And if the STEMI's gone, then it probably was just post-arrest. And if you're still concerned, you can always call med control and say, hey, can you look at these EKGs? Yeah. Should I come to you for stabilization, or should I bypass you to go to the STEMI center and just get a second pair of eyes and a brain to think about it with you?
So there's two things there actually that are really important, I think. Sometimes we forget the very rural setting, like hey, I'm 45 minutes from anyone. And
which is a huge probability.
Which is a huge probability that maybe my closest facility isn't a PCI center. And then the other item you talked about was the 12 lead EKG and how we actually need to leave our 12 lead EKG hooked up for the entire transport to the hospital. Because if it senses changes, then it's automatically going to run another 12 lead and print it out and let you know their 12 lead EKG has had changes. And a lot of people are just like, oh, I did the 12 lead, I want to take it off. And it's like, no, leave it on there. It's on there for a reason. You don't need to move it.
Let it play.
Yeah, let it marinate for a minute.
Yeah. These patients are dynamic, and if they're dynamic, we want to continuously reevaluate to see if something's changed.
And don't forget too, when you hit transmit on your monitor, it's not just going to the hospital. It goes to several people. So a lot of computers are out there going ding, ding, ding after you hit transmit, and so people are looking at that. Yeah. And if somebody sees something that maybe the doc and the ED didn't catch, or maybe the squad didn't catch, they're probably phoning the doc and the ED and saying, hey, you got a squad coming in with an inferior STEMI. So
this is a map. Squad's bringing you a mess.
Yeah.
Let me build a little bit off of what you said your in-hospital practice was, where we wheel somebody in cardiac arrest. We've put a supraglottic of choice in. Then only after ROSC and you stabilize hemodynamics and you optimize oxygenation and CO2 and all the other things, then you would switch that out. Do you feel it's appropriate if we're in that situation to switch that out, or if it's working, leave it?
The latter, absolutely.
Yeah.
If it is not broken, don't fix it. Obviously, if the supraglottic is not working, they're hypoxic despite your best efforts, yeah, you're going to have to pull that and you're going to have to put in an ET tube. But if it's working, you have a airway, and if you pull it out and fail to get the ET tube, which is possible because there's swelling and edema from the supraglottic being in there, you just went from having an airway that works to no airway, and somebody who's at high risk to have badness in their brain from any hypoxia. And the way that I exchange it is with equipment that you guys don't have. I use a fiber optic scope that I run through the iGel and use that to railroad everything over. So I'm guaranteeing that I'm getting the tube because I have extra toys, and you guys don't have that benefit, which is why it's worthwhile to wait if it's working.
Yeah, I like that.
Yeah, that is for the old dogs that, had it beat into our heads that, you were a bad paramedic if you didn't show up with an endotracheal tube.
A lot of that came down to, though, that we were giving drugs that way, too, though. I mean, now we have an IO option.
That was certainly part of it, right? Yeah. But the Airways 2 trial has really kind of pushed us away from, supraglottics.
The goal is good hemodynamics and patient care. I don't care what resources you use to do that. If the patient does well, you did a good job. And if the patient doesn't do well, you didn't do as good of a job.